Everyone who knows me, it's going to be very hard to keep to 25 minutes. I've cut down my bit on Rituximab because, well, my history with Rituximab goes back nearly, or more than 20 years, actually. Okay, so I work at UCL. I've got a PhD student working on ME, but this is a whole new area for me. My expertise, if you call it that, is in autoimmune diseases, inflammatory diseases, mainly patients with rheumatoid arthritis, which I perform with Professor Edwards, who some of you will probably know. The interest in ME-CFS came from when we read a few papers, or the first paper by Drs. Flug and Meller, that Rituximab seems to work in ME-CFS. I knew nothing about this disease at all. So after Flug and Meller came to us, contacted us for some advice, I had a quick look at the literature. And for me, as an autoimmune person, there was no evidence of inflammation in these patients that I could see, but there seemed to be a likely immune system involvement, but it was all very confusing. And then when I looked at the worldwide distribution, the prevalence was enormous. It's up nearly to rheumatoid arthritis. And again, like autoimmune diseases, it's more common in women. But the age of onset is bimodal. There's an early, that Dr. Spates talked about, adolescents and children, but also in the early 40s, late 30s and 40s. So immunologically, it's quite interesting. So from what my sort of beginner's look at the disease, what it seemed to me was a combination of physical fatigue, cognitive impairment and immune disturbances in a way that coincided to give a chronic disease. Fane, some of you may also know, when he started working for me, he too had never heard of ME-CFS, and so he started talking to the patients that we were recruiting for our studies. And we're both struck by these quotes. I was healthy and really fit. I feel increasingly isolated. I cannot recharge my batteries. Thinking, cognitive skills were really exhausting. And the most important thing was that they were never taken seriously by specialists, and they still don't. This, of course, you all know about. And my department, life has not been easy in my department of rheumatology, actually. But still, we just ignore them. Anyway, this fatigue, of course, we're very familiar with it in autoimmune rheumatic diseases. But we all get fatigued, but it's temporary and relieved by rest. And in autoimmune diseases, it's relieved by medication, usually. But medically significant fatigue in ME-CFS patients, sorry, I'm not touching it, I promise, was different. It was clear to me it was different. And in the absence of inflammation, which you can associate usually with cytokines in autoimmune inflammatory disease, this was puzzling to me. And then all the other associated symptoms were many and various. So you can see from the outside how confusing it was trying to make any sense immunologically of what could be going on. Looking at the research profiles, there was this psychosomatic disorder kept coming up, and I thought, well, it doesn't seem to me psychosomatic, it seems very physical to me. Most of the clinicians I talked to, particularly in rheumatology, are very skeptical because there was no obvious pathology. You can't see any swollen joints, you can't see a rash. And they said, well, there's no point being interested in it anyway because we can't do anything. We don't know how to manage these patients, we really don't want to see them. And there are no obvious therapeutic targets. More recently, of course, I'm sure we're all, this has been referred to earlier, this wonderful document from the IOM in the States defining the illness of chronic disease and changing its name, as you've heard, to SEED, which hasn't been taken up. But this was encouraging. So the points, the main points that encouraged me to go on was that the patients have struggled with their illness for years before receiving diagnosis. The cost, of course, is huge. And maybe if we just tell people how much this disease costs, maybe they'll sit up and listen a bit more, but we've all been trying for ages. And the health providers, they've got to learn that this is a serious disease and they must learn to cope with it. It is a misconception that it's a psychogenic illness. And this name, I don't know what you all think about this change of name, but it doesn't seem to have taken off, but at least it's a start. So faced with all this, we were further encouraged to keep going with our research. So I think the consensus opinion now amongst researchers, and there's an increasing number of people in really big departments, that we all agree that it's possibly immune, inflammatory condition. It's caused by an inability to cope normally with oxidative and nitroactive stress. There are many different abnormalities linked to this. It's usually preceded by infection, but the most important thing is this link between the brain, the immune system, obviously the gut as well. But the effects, the main thing I think from now my several years' experience is that metabolism is really significantly disturbed. And there are 4 key papers which you probably all know about in top journals now, with a consensus really that there's something wrong with the metabolism. Right, so that's just my sort of introduction to what convinced me that this disease was definitely worth investigating further. I'll just tell you a bit about Rituximab. Rituximab in autoimmunity works best in conditions where autoantibodies are part of the disease process, because it can turn off autoantibodies and actually leave the normal antibodies reasonably untouched. I'll talk about that. And it did seem to work. There are now 3 published studies by Øystein and Olav from Norway, who are absolutely incredible. We worked very closely with them. I'm just going to talk about a bit, as I said, I could talk forever about Rituximab. I'm just going to tell you what the treatment consists of and some of the little things about how it works. I'm sure you all know that B cells are the precursors of cells called plasma cells that actually make antibodies. B cells are part of the immune system that is constantly circulating around. They're sort of like round lymphocytes. They're fewer in number. They make up about 10% of the mononuclear cells. T cells, there are about 10 times more T cells than B cells. Now, new B cells, rather than unlike T cells, are coming out of the bone marrow every day. In fact, 1,000 million new B cells come out of your bone marrow every single day. And they circulate around. Most of these die, actually. But if they come across an antigen or bacteria or virus or whatever, they get stimulated and then they form either these cells that make antibodies, or they go and hang around in your lymph nodes. But they do recirculate between these lymphoid organs. And so antibodies are the sort of soluble form of the receptor on each individual B cell. Each B cell has a different receptor. Their main role, of course, is to help clear microorganisms from the body. In fact, most antibodies are secreted from the mucosal surfaces into the gut and the lungs, etc. That's where most of your antibodies go, so they're constantly keeping things under control. And as I say, each B cell has a different receptor which recognizes a different shape on targets. So that's all, it all works extremely well, of course. Different. And also the other unique thing about the immune system is that it remembers what bugs you've come in contact with before. So it'll specifically remember whether you've seen flu or tetanus or whatever. And these memory cells, again, are the ones that live in the lymphoid tissues, and they're ready to make a much more rapid response when they see that same thing again. And of course, in autoimmunity, you get antibodies to self. This is usually bits of debris from cells that should normally be got rid of quietly, but they don't. And this can be in many different ways. Again, I don't have time to go through all these, but antibodies to self usually cause inflammation, like in lupus and rheumatoid. They can form these so-called complexes. And if the antibodies keep being formed, these complexes just cannot be got rid of. There are also antibodies that damage or change the function of particular cells. For example, when you have thyroid disease, the antibodies can actually change the way the cells make the hormones, how they it can clear the hormones too quickly or to slow down the clearance of it. And in vasculitis, there's some that influence the lining of the blood vessels. The other really interesting one, where there's again a link with infection, particularly Epstein-Barr virus, is Sjögren's syndrome, where you get, and this may be relevant too with the possible use of IVIG, intravenous immunoglobulin, is that this relationship between the types, there's loads of different types of B-cell responses, and there's sort of natural antibodies and adaptive antibodies. And so you can get confused here, it's usually triggered by a virus infection. There's more interest in this lately, so watch this space. Okay, so what is Rituximab? Rituximab himself is an antibody, and it was specifically developed to kill mature B cells in lymphoma. So certain lymphomas express the antigen recognized by Rituximab, and it works very well. So what happens when you get treated? These are your B cells here. And when you're coated with Rituximab, you recruit the body's normal sort of fighting mechanisms called complement, or just some phagocytic cells. And these are recruited and both can kill the Rituximab-coated B cells. Now, it's not all B cells that are killed, which is why it's so useful, really. As I've said, you've got all these new B cells coming out every day from the bone marrow. Rituximab binds to this antigen called CD20 on cells in the periphery. This pink represents the peripheral immune system. And it kills all of those that are floating around in the blood, and a lot of those that are actually in the lymphoid tissues, and a lot of the memory cells. It stops these cells making plasma cells immediately, but it doesn't kill off the plasma cells that are resident, usually in the bone marrow, that are making your protective antibodies, like against tetanus or streptococcus or whatever. And also it doesn't affect the stem cells, because it's nice to be able to regenerate your B cells. Okay, I'm just going to just summarize the studies that the Norwegians have done. They had 3 separate studies of intervention with Rituximab. But firstly, what is Rituximab treatment? In autoimmune rheumatic diseases, we give a gram of Rituximab usually within a 2-week period. And then what we do is we wait and wait and wait, and monitor the patient to make sure the B cells have gone. Because one of the main reasons our patients don't respond is if the B cells aren't actually removed. So it's very important to check the B cell count. So what happens to the B cells? The B cells in the circulation are killed very, very quickly, within days. And also it stops the new B cells being made, because the Rituximab binds to the early B cells just before they're going to come out of the bone marrow, and it stops the new cells coming out of the bone marrow. And of course it turns off antibody production, but it turns off quite slowly, because the half-life of antibodies is about 4 weeks, and you'll just be stopping the B cells that are already committed to making antibody, but to actually lower the levels, it does take a little bit of time. Now this looks complicated. It is. These are lymphoma patients. These are the first 3 patients that Oyster and Olav treated in Norway. Now this scale here is no symptoms and severe ME-CFS. These patients had lymphoma and ME. So the R is where they get rituximab, and of course in lymphoma you often give courses of treatment. But if you just look at the response here, so they get better, and this is about 10 weeks, this is weeks. It's about 10 weeks after getting rituximab, the disease gets a bit better, then they relapse, and then they're treated with the rituximab again. So you've got this cycle. So they were really struck by this. This is what inspired them in 2009 to do a bigger study. But the lag is characteristic of what we see in autoimmune rheumatic diseases, which really got me interested. So to me it looked just like we see, implying that autoantibodies are indeed part, somehow, of the disease process. As I've said, in other diseases where autoantibodies are involved, the clinical response often takes months, sometimes up 3-4 months in some of our patients. And of course it will depend on how quickly the antibodies and the B cells committed to making these antibodies are reduced. There are other more complicated reasons as well, particularly if they're producing some kind of cytokines. So those ones will sometimes take a shorter time to be removed, but patients do tend to take some time to respond. And then Flügen-Meller did a placebo, double-blind placebo-controlled trial of 15 patients treated with rituximab and 15 placebo. And again, they followed our protocol, and the patients were followed up for 12 months. And there was both self-reported and physician-assessed symptom scores. And they followed the CD19 counts, and all the patients depleted their B cells very well. So there's no reason for them not to respond. So this is the follow-up results at 12 months. 9 of the patients treated with rituximab responded, only 1 with placebo. And the duration of response ranged from 25 weeks to more than 44, which is, again, what we find in some patients with rheumatoid and lupus. In fact, we've had some patients with lupus who've now, 7 years after 1 course of rituximab, 7 years on, has not relapsed. But usually in our cases, the patients do relapse. This patient has been now followed up for 5 years, and she hasn't relapsed. Okay, and the other thing that's of interest, obviously, is to look at the pattern of response. So this is in their next publication. This is the KTS2 trial, and the scores here are the opposite way around than the last time. So if you get better, you go up here, not down. So these are all different symptoms: fatigue, cognitive impairment, etc. And you can see that this improvement in symptoms seen in the patients mostly follows a similar course, but not always, which to me is even more interesting, in fact, because it's such a complicated condition, group of conditions, spectrum of conditions, that you wouldn't expect everything to respond in the same way. You expect there's a lot of differences in the way they can respond. They have also, the Norwegians have also done a maintenance treatment trial, and they've shown a much longer response if you keep the B cells away for longer periods. So there does seem to be a link between actually keeping them away, keeping the B cells away, and doing well. And I'm sure you all know about the phase 3 trial that is underway at the moment, and hopefully there'll be some results in August, September this year. So what happens after rituximab? Well, the B cells do come back. All your new B cells start coming back about 6 months after treatment. Unless, of course, you get another dose. And as I've said, the protective immunity is not significantly affected in most cases. Okay, there are, of course, patients in my area, my usual area, where they don't respond because some autoantibodies, like those protective antibodies, are made by long-lived plasma cells, and they don't get killed by rituximab. This is low levels of immunoglobulin. You can get sort of a bit of an immunodeficiency phenotype, but it's not, doesn't seem to be that severe, and you can actually replace the immunoglobulins if it does. So what possible autoantibodies could there be in ME-CFS. We talked about postural orthostatic tachycardia syndrome earlier. There's 2 papers now, or more, showing that there are antibodies to neurotransmitter receptors. There are also, in other autoimmune diseases, antibodies to the mitochondrial energy metabolism machinery. And this, I think, is quite interesting. There's also, in ME-CFS, antibodies, again, to these beta-adrenergic receptors reported by Carmen Scheibenbogen. I'm Australian, I can't speak any languages whatsoever. And this hopefully will be looked at in more detail. So this would explain some of the things. And the other antibodies will interfere with mitochondrial synthesis. These are mitochondria here. And in fact, there have been abnormalities reported in several areas in the cytosol and mitochondria where autoantibodies and other diseases have also been shown to act, particularly against pyruvate dehydrogenase. Okay, so at UCL, we're trying to identify patients most likely to respond using biomarkers, but we're waiting for the Norwegian trial to really see what's going on. And there are many other B-cell directed treatments if Rituximab works well, or it will depend how the B-cells are causing the disease. So in conclusion, it seems to me that autoantibodies may be involved, and what we've been concentrating on for the last 2 years is developing a system to examine this. And I'd like to thank CARE4ME and Nancy for inviting me to Belgium, not been here before, and I wish you luck. Thank you.